We're going to go ahead and get started with session 2. Oh, great. My name is Matt Ernest. I'm one of the interventional cardiologists at KU. DJ and I participate in the Lariat program. I wanted to welcome you again to Kansas City. Thanks for attending the program. Our next session, we're going to have a series of talks. The first one is, I'll introduce our next speaker, Dr. Berenbom. He is the director of the Block Heart Rhythm Center and is professor of medicine at University of Kansas Medical Center. He did training at both Northwestern University and Barnes Hospital and Washington University at St. Louis, and he's going to be talking about risk assessment tools for stroke prophylaxis and bleeding.
Good morning. It's a pleasure to be here. I have a relatively short presentation, try and keep us on schedule. I just want to congratulate DJ on putting together an incredible and very innovative conference. And I'm also going to take some time here, and I'm going to review everything they taught me in medical school about the left atrial appendage, the ligament of Marshall, the pulmonary veins, pulmonary venous vagal plexi, and anything else you can think of in this part of the chest. And now that I've done that, if we can move ahead to my talk. I need to figure out how to change slides. Okay. So I think you've actually already seen this slide, the CHADS risk score, and this is something that was developed several years ago, and as was pointed out, it has some weaknesses. And if you look at how the CHADS score is supposed to be used, the biggest weakness is that depending on the patient population, 30, 40, 50% of the AFib patients have a CHADS score of 1, and patients with a CHADS score of 1 can receive either aspirin or Coumadin, and that's the traditional drugs. Obviously, we have 3 new drugs now that you can add to the Coumadin. But a lot of physicians say, oh, score's only 1, I'll just give this person aspirin, and the problem is that that's really not adequate anticoagulation. Okay. So the CHADS-BAS score was developed, and basically that adds risk factors of vascular disease, going to younger ages, adding female sex, gives you the opportunity to have higher scores, and moves a lot of those 1s, even moves CHADS 0s into a much higher risk category. And if you look at this, typically there just aren't that many people with a CHADS-VASC of 0. But if you look at a CHADS 1, a 1.3% risk rate, CHADS 2, 2.2% risk rate, and it does escalate until you get to some pretty small numbers here where these percentages are probably not all that meaningful. But again, the important thing about CHADS versus CHADS-VASC, if you look at people who have a CHADS score of 0 and supposedly a stroke risk of 1.9%, which is not low, and you look at what the CHADS-VASC score is for those people, you can see that a good number of them will have a CHADS-VASC score of 1, 2, or 3, and stroke risks that get up over 3%. So again, the CHADS-VASC, which is a little more complicated to use, but does give you a much better assessment of individuals' risks. Now, just in the last couple of months in circulation, there was a paper which came up with a new risk system, R2 CHADS, And this included renal dysfunction as a predictor of stroke and systemic embolism. And renal dysfunction is defined as a creatinine clearance less than 60. And they developed the cutoff here in the ROCKET-AF database, so it was 14,000 patients. And then they looked at it in the Atria cohort to see what it added to the CHADS and what it added to the CHADS-VASC. And their assessment was that it was modestly better than CHADS and even a bit better than the CHADS-VASC. Now, personally, I'm not going to start running around and using this on a routine basis. I think it would need more validation. But I think that it does speak to the fact that we are still trying to sort out risk factors in terms of which patients with AFib are at high risk for stroke and which patients deserve anticoagulation, or as seems to be the interest here this weekend, potentially an intervention. Now, bleeding risk scores, and I'll have to admit that I use the CHADS and CHADS-VASC scores all the time. They help me decide who to anticoagulate. They save me a lot of time because 10 times a week, it seems, I get a call from somebody or a text or an email, and it says, Mrs. So-and-so is going to have this or that procedure, and their surgeon wants to hold their Coumadin for 3 months before and 3 months afterwards. When you have this documented in the chart, and I can say, well, what's their CHADS-VASC score, and it comes back 6, and I go, I don't think that's going to happen. We're going to have to figure out something a little tighter than that. Whereas if their score comes back 1, it's like, sure, let them go ahead and, hold whatever for 2, 3, 4 days and a day or two after, depending on what the drug is. At any rate, bleeding risk scores, and these are not, I've really never used the bleeding risk scores. I guess because I feel like I'm more concerned, we just need to manage that risk. But there are a variety of these bleeding risk scores. The HAS-BLED is the one that seems to be most widely recommended, and because it's the simplest and the most serviceable. And again, hypertension, which is in CHADS-VASC, abnormal renal function or abnormal liver function, a point each, stroke, which is in CHADS-VASC, bleeding, and bleeding is obviously highly variable. You can have the person who's had a minor nosebleed, or you can have that patient with Osler-Weber-Rondeau that is bleeding all the time without any additional anticoagulation. Labile INRs, which doesn't really count for much if you're on one of the new oral anticoagulants. Elderly, age greater than 65, well, that's pretty much all of our patients. And then drugs, and this is drugs that increase bleeding. This is not cocaine, and alcohol. It was evident that everybody out there says that you don't use this score to exclude patients from oral anticoagulant therapy. And the reason for that, again, is that a lot of the things that add to your HAS-BLED, add to your CHADS-VASC, and if you look at a net clinical benefit analysis, your higher HAS-BLED scores are your higher CHADS-VASC scores, and even though your patient is at higher risk for bleeding, the net clinical benefit still very much tends to favor anticoagulating these patients. So I think the right way to use the HAS-BLED score is not to say, they've got 2 points or 3 points or 6 points, we won't anticoagulate this patient, but it's rather to identify reversible or modifiable risk factors, so that if you've got somebody whose blood pressure is 200 over 100, you get that taken care of. If they're on other anticoagulant or blood thinning agents, you can consider if you can get rid of some of those, and I think Dr. Tadros will speak to that. If they're drinking, can you get them to drink less, et cetera. So my conclusions, all patients with non-valvular AF should have a formal stroke risk assessment, and I think CHADS-VASc is the best system for that. Only truly low-risk patients, so that's really lone AFib, age less than 65, don't need antithrombotic therapy. So the vast majority of AFib patients really should be on antithrombotic therapy. And the HAS-BLED score can help identify modifiable risk factors that need to be addressed, but should not on its own be used to exclude patients from anticoagulation therapy. So, thank you.